So I was asked to talk to you about 3 topics: how to monitor MPN patients, a little bit about women and MPN, and then about new treatments. We already know, and maybe some of you know already from personal experience, about the many things that can happen to patients that have an MPN. On this slide, I tried to summarise all of those, and they might well range from many patients actually being well and continuing to be well all the way through their disease. And it's important to say that this can happen for really quite many patients. Otherwise, there can be risk of having a more aggressive disease, headaches, visual disturbances, blood clotting events, enlargement of the spleen, and symptoms that come with the disease. Also, when we think about a patient, sometimes I think that we think only about a disease, but it's important to think about a patient in the context of their whole life and the impact that having a condition, whatever that condition is, if it's diabetes, high blood pressure, blood cancer or other condition, can have on the whole person. And so it's very important that we work in looking after patients, in my opinion, by thinking about all of these things: their emotional well-being, their financial well-being, the stress of disease, etc. So we have to think about all of these things. Although what we might focus on today is medical information, we must think of all of these things. So let's take a look now at the individual MPN in a little bit of detail. Starting first with too many red blood cells, polycythemia vera. So I think you heard already that there can be some clinical features for patients with polycythemia vera. Maybe they're familiar to you. And these are the kind of things that we might see that our patients complain of: headaches, itching, weight loss, redness of the face, a little bit like this picture maybe, and sometimes enlargement of the spleen, as well as other features. So medical treatment for polycythemia focuses mainly upon controlling the blood count, particularly important to control the amount of red blood cells, and we make this by doing something called phlebotomy, which means removing blood. And then sometimes we use drugs to control the blood counts. Many patients probably taking hydroxyurea or interferon. More recently, ruxolitinib, a JAK inhibitor, which we'll talk about in a minute, is a newer drug. But most patients with polycythemia should be taking an antiplatelet drug. Aspirin is an example. But not all patients need all treatments. I would say all patients usually need phlebotomy and aspirin, but then we must decide when do we need to use a drug and when do we not need to use a drug. So we might decide that a patient is low risk, they don't need an extra drug, or they maybe are high risk. This refers to risk of blood clotting or thrombosis, and then they need a drug. So low risk would be a young patient with no history of blood clotting. And we would need to be cautious, though, if the platelet count becomes very high, because there's increased risk of bleeding. A high-risk patient might be somebody who's either over the age of 60, and this is very difficult for some patients, just because you were 59 one year and then you're 60 the next year. Really hard. And if they are a young patient, if they already had a blood clot, then they need to have a treatment. And then more than that, more risk than that, is a patient who is not well controlled on their current treatment, especially hydroxyurea. So what happens then over time with the disease? This is, of course, really important. We must make a diagnosis, we must make a plan, and then we monitor the plan. But what might be happening in the future for patients? So this is some idea about the time course of disease. At the beginning, you may have the disease but not have the diagnosis. Some patients have a blood clot in that time. Then we make the diagnosis, and then patients live for a very long time with this disease. Most patients live for a very long time without a change in their disease, but over many, many years, there is a risk of developing more aggressive disease, myelofibrosis, which we'll come to talk to later, or for a smaller percentage of patients, probably even smaller than on this slide, risk of leukemia. These figures are actually quite uncertain, and here is some data taken from a different publication. But you notice here that we highlight the risk that we can really modify here is clotting, thrombosis, and also of bleeding. And this is what we aim to do with treatment. We don't think that treatment can really affect what is the risk of fibrosis. Some treatments can increase the risk of leukemia, but not probably modern treatments. So some patients, we use a lot of medical terms, and sometimes people will say, well, what does it mean? How will I know if I have a blood clot, and where could a blood clot be? And so on this slide, just to show you that there could be many parts of the body where you could have a blood clot because of polycythemia. This might include a blood clot in the leg, in the blood supply affecting the liver and the spleen and the bowel. Some patients may well have a cerebrovascular accident or stroke or a heart attack, for example. All of these are increased by risk of disease, but all of these also happen in patients that do not have MPN. So there are other things that you must do to keep yourself fit and healthy, as well as the doctors do in managing your disease. Okay, so before we look at some patient stories, let's also look at ET. I have another cartoon for you. This is what my parents thought that I studied for my doctorate thesis. The main feature of this condition, you already heard this from Bjorn, but just to show you some pictures, these are platelets, and this is a patient with ET that has too many platelets. So when we make a biopsy for a patient with ET, they have a lot of these big cells. These are the platelet-making cells. They're called megakaryocytes. Here's some of them in close-up. And these are the things in the bone marrow that are making the platelets. Now, platelets are very active. They're part of the body's first defense in making a blood clot. So now patients with ET, they usually have a normal red blood cell count, but they have a lot of disease features in keeping with this high number of blood platelets. They can get blood clots in the big vessels, like we already saw for PV, but they also often have something we call small circulation or microcirculation features. So they can get pain and tingling in their hands and feet, sometimes atypical headaches, and sometimes, even though the platelet number is very high, the platelets don't work very well, and so there is a paradox. The patients can get bleeding. So if you are a patient with ET, you may get the same big clots in veins like patients with polycythemia, but you may also get these small blood vessel problems shown here in the toes of a patient, which are becoming red and blue, and this is thought to be platelets in the small blood vessels. Sometimes we see this described in the literature as erythromelalgia. This comes from the word erythros, red in Greek, melos, limb, and algos, meaning pain. And then some example of hemorrhage. They may be simple hemorrhage underneath the skin, rarely hemorrhage within the body, usually though more superficial, sometimes also nose bleeding. So just like in PV, the aim of treating this condition is to prevent clotting and bleeding. This condition has the similar risks of developing fibrosis and leukemia, but our aim is to prevent clotting and bleeding. So again, we use a risk adapted. If you are low risk, younger than 60, no blood clot in the past, then you might just get aspirin or maybe even no aspirin. And if you're high risk, age over 60, previous thrombosis, very high platelet count, then you would have a treatment. Some other things that we might be thinking about: is this a JAK2 or a CALR mutation? I know Bjorn introduced this. Whether the white cell count is high, whether the amount of the abnormal mutation, especially JAK2, is higher or lower, and then whether there are other risk factors. For example, is the patient smoking? Do they have blood pressure? These are not easy to fit into this scheme, and we sometimes look at the individual and manage the individual. So one way to divide this is shown here. If the patient is low risk with cardiovascular risk factors like smoking and a JAK2 mutation, maybe we would use aspirin. But if they don't have risk factors and they don't have the JAK2, then we might not. This is still being discussed. For other patients that fall into the high risk, we would usually use aspirin and drugs. A drug that is used mainly for ET, not for other diseases, is anagrelide, for example. So if we look at the same risks that we looked at for PV, for ET patients, you can see that the risks are actually a little bit lower in terms of change of disease, and most of us would say that survival for patients with ET is almost equal to the general population, but we need a bit more modern data, hopefully from your cancer registry, that could help us to decide this. So if we look on a purely medical basis at disease, not at the whole patient picture, then we need to be watching many different factors to decide, is this patient's illness well controlled or not? So on this slide are all of the things that we would be looking at when we're looking at you to see how is the disease going. How are your blood counts? How often do we need to take blood from you if you're a patient with PV? How are you getting on with your treatment? Is there any evidence of change? And how are your symptoms? Okay, so let's take a look at some patients now, because this is always a good way to look and to think about these conditions. I hope this man isn't in the room. So here is a patient. He's a man, he's 59. He comes with an abnormal blood count. He has a quite high hemoglobin reading. The white count and the platelets are normal. We make a biopsy. It's not normal. There's an increase in all of the cells, especially the big megakaryocytes. He has some blurred vision and some headaches, and he has a mutation test and is JAK2 positive. So these diseases are all diseases of a very long time course. So let's take a look at how this patient does. Initially, the patient just has phlebotomy and aspirin, and this is the case for about 15 years. But the hematocrit is not well controlled. We like this to be 0.45, and the spleen is becoming enlarged. So then the patient is put on hydroxyurea. He stays on this drug for about 2 years, but the platelet count becomes lower. The dose is reduced, but he needs quite a lot of phlebotomies. So the disease is not really very well controlled, even at this time point. But notice that this is about 20 years from the original diagnosis, with this patient staying well. So really the point of this is to show you about phlebotomy and about, if you look at this patient, how much of the time he is out of control. And so this is not good control of disease. We have to make a change for this patient. Now let's take a look at another patient. Here is a patient, another man. He presents with angina, which is heart disease pain. He has a high platelet count. In the bone marrow, the platelet-making megakaryocytes are increased. He has no other symptoms and is found to be JAK2 positive. So this patient has high-risk disease. He's got a strong cardiovascular risk factor, and he began taking interferon, which he took for many years, but he had some side effects of this drug with depression and low mood, and the white blood cell count after many years was a bit too high. And then he was switched to hydroxyurea, which his mood improved, but then he developed some other issues with an enlarging spleen, raising the possibility that he might be developing myelofibrosis. Okay, so let's take a look at myelofibrosis now. So here there are abnormal cells in the bone marrow, but also the bone marrow itself is abnormal with the build-up of scar tissue. The spleen becomes enlarged because the blood-making tissue moves to the spleen, but also the blood-making tissue can move outside of the bone marrow. This is known as extramedullary hematopoiesis. And patients with myelofibrosis tend to have more symptoms, some of which relate to the spleen, but also some general symptoms. Now for some pictures. This is the blood of a patient with fibrosis. The blood cells are distorted. They're known as teardrop cells. They look like a teardrop. We use criteria to make a diagnosis which include those features in the blood, include the features in the bone marrow and fibrosis, the presence of mutations, and then some other features like a blood measurement called LDH, if the patient has a low hemoglobin and an enlarged spleen. So these are the things that we look for to make a diagnosis of myelofibrosis, but to also look to see if ET or PV have changed to myelofibrosis. For example, here is the blood film again with the teardrop cells, but also some immature cells. This is an immature red blood cell. The bone marrow is also a bit different. Again, the megakaryocytes look abnormal, but it's not the same as it looks for patients with ET. Just to say, in my practice, I don't make bone marrows regularly on my patients with ET or PV to look for the features of myelofibrosis. How does it look to be a patient with myelofibrosis? Actually, there are two faces, and increasingly we think about JAK and JAK mutation, the same as or change of the JAK pathway caused, for example, by a CALR mutation, but we also think about inflammation. Inflammation as a cause of myelofibrosis and as a cause of some of the cytokine, of some of the complications. For example, symptoms and some of the abnormal blood counts, for example, may be due to inflammation. And this can be an important target for us for treatment. Okay, so I think we might skip over this slide to catch up some time and just show you a picture of the fibres in the marrow for patients with fibrosis. You can see that there's a sense of, if this was water, that it would be moving and the blood cells look like they're streaming, and this is the fibre being laid down in the bone marrow. We think in part this happens because of the abnormal blood cells triggering the abnormalities in the bone marrow. So there can be many features of this disease as we make a diagnosis. And again, I think maybe we should move forward from this slide. So what happens to patients with myelofibrosis? And this is a study of a lot of patients from a big hospital in America, the Mayo Clinic. You've probably heard of this. They studied 311 patients over many years. Almost 3/4 of the patients needed some type of treatment. Nearly 20% of them had their spleen removed. This is the spleen being removed. It's a big organ. It's a very risky procedure, and we don't do that so often now. And around 9 to 20% of patients over 5 to 10 years developed leukemia. The average survival for these patients at this time, which is some time ago, was about 6 years, but is quite variable. So because the disease is very variable in its time course, and because we might use some treatments that are very aggressive, like transplantation, which has a big risk, we like to give patients an idea of prognosis, and we can use a number of different scoring systems. These are being changed all of the time. In fact, there are at least 2 more now, based on different factors for the patient: their age, their blood count, whether they have symptoms, whether they need transfusion. And these are all of the different scoring systems that can be used to divide patients up according to what their risk from the disease might be. So using these scores, we can divide patients up into different prognosis groups, and then, for example, in the patients with a high risk of dying from their disease in just a few years, we might choose to use aggressive treatment like bone marrow transplant. These scores are changing all the time, and actually now we introduce the idea of, does it matter which mutation that the patient has? And it's becoming more obvious that patients that have the calreticulin mutation, especially the type 1 mutation, have a better prognosis than patients that do not have that mutation. So we begin to learn, and I will talk later about how we integrate molecular mutations into our risk prognostics for MF. So myelofibrosis is a very complicated disease, and we may well have many different goals in treating patients. Cure through transplant carries a very high risk. Other options are to try to prolong survival in another way. We have to think also here about blood clotting, managing symptoms, and also primum non nocere, the complications of the treatments that we use, especially treatments, for example, like transplantation. So one way to think about how we would think about treating a patient with myelofibrosis, whether they have the original diagnosis or whether they have developed it after ET or PV, is that we calculate their prognostic score, we look at their symptoms, and then we think, okay, so how do we manage the patient? If they're low risk with no symptoms, we might observe them. Some doctors might use interferon in the hope that it stops progression of disease. If they have symptoms, then we must try to address the symptoms if we think that's necessary. One way to think about this is to use a JAK inhibitor or other treatments, for example, antihistamines. Then we have to think about the individual features of the disease, whether there is a problem with anemia or an enlarged spleen, or all of the different problems that the patient has. And it is only for the patients who have the more aggressive disease, intermediate 2 and high risk, where we think about this option of transplantation, and initially where we tested the JAK inhibitors. So we took a look at the individual diseases, but there are other things that we should be doing when we're thinking about managing MPN. We should look at the disease. We took a look at how we do that. Is it well controlled? Is it changing? Is the treatment still appropriate? But it's also important to think about, do we understand our patient? Do they understand the disease? Do we measure the symptoms and quality of life? Do we think about side effects of drugs? And do we look at other changes in their health or vascular risk? So all of these things should be exchanged between you and your clinical team. And together then we can build a therapeutic relationship where we exchange information that's important to keep your disease well controlled and you as well as possible. So the other aspect of this is who should do this monitoring. Is it a doctor? Is that an expert doctor? Is it a family doctor? Actually, it should be all of them. In England, we have some special nurses who are specialised in diseases and do a lot of patient disease management. And should this be in your home, that you Skype your doctor? Should it be in a hospital? Should it be done via the internet? All these are possible and they're changing all the time. And so we need to try to work together to make the best possible solution in our health setting and for our patients. And the last thing, this is the view from one of my offices at St Thomas's Hospital. This is the Houses of Parliament in London. But we must also work together to make sure that blood cancer is recognised as an illness, especially these rarer illnesses, and make sure that we have the resources and the treatments available for you, our patients. In my last slides, I want to show you some work we've been doing in the unit in Cambridge and with colleagues across Europe, trying to use the genomic data to make a personal prediction for a patient. So in terms of number of abnormalities, here are MPNs. This is myeloid leukemia. Here is myeloma, another blood cancer. And here, very complex, is a skin cancer. So MPNs are quite simple, but it's also very easy to study them because we can just take some of your blood and we're already studying in detail the blood cancer. This just shows you what we did in this work. So we took 2,000 patients, many of them were ET patients. We looked at 70 different genes, more than 1,700 different changes within genes, and we did a lot of analysis. And this is to emphasize, you can sequence the gene, but you have to know what to do with the data. You then can do a lot of statistical modelling to look at how the information clusters together, and then we use this to make a model. So just as an example here, we can see that the JAK2 mutation clusters with specific abnormalities, these are chromosomes, in a different way from the CALR mutation here with different chromosome abnormalities. This was then put together with very detailed information about what happened to these patients. So these are patients where we have information about their disease course now running for more than 20 years. And so we put in the information about the patient, and then we looked at the outcome for the patient. This is really important. We shared a joke earlier about how critical it is to be 59 or 60 if you have ET. In this model, you can use age as a continuous variable, not just you are less than or over than. And we know that that's very important. So we put this model in, here is a patient. And the model then allows us to get a printout for the individual patient. And this predicts how would the patient be after 5, 10, 15, 20 years. This patient is 79, a female diagnosed with ET. We know the blood count, we know the mutations in CALR and some other mutations. And we can then predict at different time points, is the patient likely to die but just has the disease the same, they die of something else? Are they likely to develop myelofibrosis and die? Are they likely to die from acute leukemia? Are they likely to be alive with myelofibrosis, etc.? So this could then predict the course of the disease for the individual patient based on very complex data that we put into the model. What actually happened to this patient? This patient developed myelofibrosis and died after 5 years. And you can see that actually the model predicted that this would happen, the patient had a 38% chance of that happening within 5 years. So the model is actually accurate to around 80%. We are trying to validate the model now with more information, but it's the first time we've been able to use a very individual data set and to be able to integrate the kind of information that we can get now with increasingly powerful tests in the laboratory. So we hope that we could use this model to make an individual prediction for a patient. But we need to be able to do more data collection. I can see there's a question already. Yes?
Yes, a short question is, do the patient want to know this? Of course, it's different between different patients. We're all different as humans. Yes.
Well, maybe we should ask the audience.
Yes.
So if we could make this kind of analysis for you, and we could give you a printout that might give you what the risk might be for you at different time points, maybe you could put your hand up if this is something you would like to see. So a bit mixed.
That's a yes for one bit.
I think it's a bit mixed, actually. And actually, this is something maybe all of us, if I see a patient and I ask the question, do you want to talk about prognosis? Quite sometimes the patient says no. Sometimes their spouse says yes. But it's not only just for the individual patient. We could also use it to help us to predict when it might be good to use high-risk treatments like transplantation. This is a very difficult question for patients with myelofibrosis. I cut the slide, but if you look at patients that we might be referring for transplant, using this tool, you can see a lot more difference between the patients. So you could channel the patients more appropriately to higher risk treatments. You could, using the analysis, the genetic analysis, maybe target a treatment a bit more to a patient. We saw that with imetelstat, for example. I didn't show another picture of London as my last slide, except to say that we need to use many different tools and many different things to think about the future for these diseases. So I find this quote helpful. And another picture of London with no rain. Thank you.
Thank you very much. Thank you.
So we already discussed the complications of these conditions, but we also need to focus on which are the complications that are very relevant to women. These diseases can affect patients who are young, and especially ET is more common in women than in men. So when I first got married, my husband bought me this book. Men and women are different. But are they really different? So let's take a look at some disease differences before focusing on the obvious things that we need to think about for ladies with MPN. We already said that ET is a bit more common in women, myelofibrosis a bit more common in men, and more men than women will develop polycythemia vera. But these are really small differences. You're slightly more likely. As an individual, that doesn't really make a big difference, and nor does it really matter to us as doctors when we're treating you, but there are some interesting facts when you look at large populations of patients. For example, in the ECLAP study, which was a PV study with aspirin, women were more likely than men to have clots in the veins and small blood vessel disturbances, but men were more likely to have disease in their arteries and, for example, heart attacks. Clots in the splanchnic veins, that's in the abdomen, more often happened in young women. Here you can see 5 out of 6 cases of this condition called Budd-Chiari were women. And there's also a greater likelihood for women patients to have blood clots in the veins in their brain. But the more obvious things that we need to focus on are issues around pregnancy, contraception, and management of the menopause. So recommendations for contraception are based on very little evidence. In fact, much of this is based on very little evidence, but it's quite a common question, so I'm guessing this is why Lisa asked me to talk about this. In general, we discourage the use of estrogen-containing contraception for women, and if they need help with fertility, each patient should be assessed individually and offered extra protection against blood clotting. Concerning the menopause, while initially we felt that hormone replacement therapy was probably not appropriate, actually more recent evidence suggests that lower doses of estrogen-containing hormone replacement is okay, provided the patient doesn't have a history of a blood clot. So for the rest of the talk, I want to mention about pregnancy and think about what the outcome could be for patients. So the next 3 slides talk about what we know about outcome for pregnancy in the different diseases, and then I'm going to show you a story of a patient. So we know the most about ET patients and pregnancy because this is a disease that's common in young women, and actually the success rate for pregnancy looks quite low on this slide, but more recently we did a study in the UK and the success rate is probably about 80%. But there are still problems with unsuccessful pregnancy, especially at the beginning, and then risks of a small baby. For the mother, there is a risk of about 1 in 20 of having a blood clot after pregnancy, and bleeding risk is probably about the same, 1 in 20. As you see, we know less about polycythemia vera in pregnancy, but the outcome is roughly about the same. Myelofibrosis is much less common in women of childbearing age, and so there's very little history in the literature. But it seems that there is a higher risk for pregnancies with this disease, but I think this is probably because the number of cases is very small. So the important things to consider are, can we predict outcome for a pregnancy? We know, for example, that the platelet count will fall, and some people think, Martin Grieshammer, for example, in Germany, that if the platelet count falls, this correlates with improved outcome. If the patient already had some disease complications, that doesn't always predict a bad pregnancy outcome, but it does mean the pregnancy will be complicated to manage. Professor Teferi from the Mayo Clinic has published a paper suggesting that if you've previously had a bad pregnancy outcome, it might not predict future events, but actually our management really is based upon the disease, but also whether you've had a previous pregnancy event. So we would take note of, for example, a previous pregnancy loss. And then testing for risk of clotting or bleeding above and beyond the MPN has an unclear role in the management of pregnancy. So we know that about 50% of patients with ET have the JAK2 mutation, and there is some evidence that women who have the JAK2 mutation might have a worse outcome for pregnancy. On the other hand, the patients with the CALR mutation appear to have a better disease outcome, but we know very little about these patients in pregnancy. Also, in pregnancy, we can monitor the blood supply to the baby. And this is an example of the way we do this using Doppler, which is based on ultrasound that looks at the flow of blood. Here is a normal blood flow to the placenta, and here is an abnormal blood flow. So, as in many things in life, management of pregnancy can be very complicated, and it's really important that the patient, the doctor, and the doctor who will be managing the pregnancy make a plan, and also that they communicate the plan. So now let's take a look at a patient story. This is a young woman that I saw in my clinic actually about 10 years ago. She was 26 and she was treated with hydroxyurea. She liked riding horses and she fell off her horse and needed a spleen removal. She had a blood clot after that. She had abnormal blood vessels that were bleeding in her abdomen. She had tried interferon because this is the treatment that we usually use for younger patients. But she had a lot of complications, particularly fatigue. And she had some strange side effects in her skin with the hydroxyurea. She had many black lines appearing on her arms and legs and over her back. So she came to me with the difficult question, how can I manage a pregnancy? What is the options for this patient are complicated. She really wants to get pregnant. We could use no drug, but this is not a good option. She already had a blood clot, so she's at very high risk in pregnancy. We could try interferon again. We could use a longer-acting interferon, pegylated interferon. She hadn't had that. At that time, there was no published data for this in pregnancy, but more recently we published some data. Or we could do platelet pheresis, which means basically hooking her up to a machine and trying to remove platelets once or twice a week. Not a really good option for the whole length of pregnancy. So we don't very often do this, and it was a big undertaking. So we chose to make the pegylated interferon. Do you agree?
That was our choice too.
Okay. So what happened to the patient? She became pregnant. We put her on heparin, but she lost the first baby at 6 weeks. She then had another miscarriage and 2 further miscarriages, and she had a lot of complications on the Pegasus. So we switched her then to an agrolide and said, stop trying to get pregnant for a while. And then she became pregnant again. And unfortunately, this time, we made an unwise decision and allowed her to go on holiday. She had a massive hemorrhage and required surgery, and when she came back to the UK, she had a very big stroke. So this was really a big disaster. But actually, it doesn't end so badly. We said no more pregnancy, but she had a surrogate pregnancy, and we managed her egg collection properly, and then she had these 2 little girls. Actually, now they're about here. And here is another view of the Houses of Parliament.
And no rain.
Still no rain. And this is the end.
Okay.
Yes.